Good afternoon. I am presenting a study on foveal avascular zone morphometry and changes with anti-VEGF in patients with non-proliferative diabetic retinopathy with clinically significant macular edema. Diabetic retinopathy, it remains a leading cause of blindness among patients with diabetes. Diabetic retinopathy, a microangiopathy due to chronic hyperglycemia-induced inflammation with release of various inflammatory mediators, the major one being vascular endothelial growth factor. It results in blood retinal barrier breakdown, causing macular edema and also capillary occlusion. Normal foveal avascular diameter varies between 200 to 600 micrometer. Mean foveal avascular zone area in superficial capillary plexus is 386 micrometer square and in deep capillary plexus is 463 micrometer square. Due to capillary occlusion, a large irregular foveal avascular zone is present in patients with diabetic retinopathy. VEGF being the main inflammatory mediator, intravitreal anti-VEGF, it remains the mainstay of treatment in diabetic macular edema. Though its efforts on diabetic macular edema is well established, its efforts on foveal avascular zone remains controversial. Many discrepancies exist among the studies, some suggesting an increase, others showing a decrease, and also stable foveal avascular zone with variable parameters. In light of these discrepancies, we are doing this study to evaluate changes in foveal avascular zone after anti-VEGF injection and also to find out the changes in best-corrected visual acuity and central subfield thickness after anti-VEGF injection. Ours is a prospective study. It is done in 35 eyes of 43 patients in a tertiary eye care center between January to June 2023. And the patients were evaluated for best corrected visual acuity using logMAR chart, central subfield thickness by spectral domain OCT, and changes in foveal avascular zone parameters by OCT angiography. The things analyzed in foveal avascular zone were the average diameter of superficial and deep capillary plexus and the foveal avascular zone area in superficial and deep capillary plexus. We have included treatment naive eyes with non-proliferative diabetic retinopathy with CSME, and we have excluded these patients with other ocular conditions that affect the macular perfusion and those with thromboembolic events within 6 months. Coming to our results, our study showed a statistically significant improvement in best corrected visual acuity with a mean value of logMAR 0.4 to logMAR 0.2 and a reduction in central subfield thickness from 504 to 391 micrometer. Even though statistically insignificant, our study showed an increase in average diameter of superficial capillary plexus from 823.9 to 825.7 and in deep capillary plexus from 952.9 to 955.2. And foveal avascular zone area also showed an improvement from 551.9 to 553 and deep capillary plexus also showed an improvement from 611 to 612.9. This was also found to be statistically insignificant. Discussion. Thus, our study showed an increase in best corrected visual acuity and decrease in central subfield thickness with worsening of foveal avascular zone parameters. We have used ranibizumab, which is the commonly used anti-VEGF agent, and we have measured the foveal avascular zone parameters rather than the perfusion density, which were analyzed by the similar studies. Thus, despite restoration of normal retinal architecture with rejection in macular edema, which should show a decrease in foveal avascular zone parameters due to the centripetal movement with resolution of edema, our study showed a slight increase in foveal avascular zone parameters. These were some of the studies which showed decrease in macular perfusion. In a study by El-Nahari et al., they found out that the superficial capillary plexus density decreased after injection, and with cessation of injection, the density improved, and again with injection it decreased. In a study by Barash et al., they found an improvement decrease in macular perfusion status 3 minutes following an injection. These were some of the studies which show an increase or stability in foveal avascular zone after injections. Thus, even though statistically insignificant, our study showed that macular perfusion is slightly worsened following single anti-VEGF injection. So, multiple anti-VEGF injections might further worsen macular perfusion, and this improvement in vision could be attributed to the preserved ellipsoid layer and better regaining of inner retinal anatomy due to reversal of disorganization of retinal inner layers and the relief of Muller cell stretch with resolution of the edema. This also signifies that the regain in best-corrected visual acuity is not related to the foveal avascular zone perfusion status. From the studies, it appears that the molecular changes that explains worsening of macular perfusion are due to decreased nitric oxide synthesis by endothelial cells and due to the selective knockout of vascular endothelial growth factor in local endothelial cells, which have a pro-thrombotic effect, and also due to the progressive diabetic retinopathy contributed by other inflammatory mediators other than anti-VEGF. Thus concluding, anti-VEGF injection was found to be effective in improving best-corrected visual acuity and reducing central subfield thickness, and foveal avascular zone perfusion status worsened following anti-VEGF injection. So long-term follow-up of FVZ is required in patients taking continuous anti-VEGF. So we recommend future studies with larger sample size and longer follow-up to confirm our diagnosis. These are my references. Thank you.
These findings with the visual acuity, is it?
Yes, there was an improvement in visual acuity, but the form. Yes, sir.
So what were the findings that showed you that the FAZ perfusion actually worsened?
Actually, we have taken the average diameter in superficial and deep capillary plexus, and also the area was measured, both in superficial and deep capillary plexus.
There are few other studies showing similar findings.
Studies showing.
Or yours is the only one?
No, similar. There are studies which showed increase in macular perfusion status and also decrease and also stable foveal avascular zone parameters following injections.
Same investigative modality.
Same, both average diameter. We have used OCT angiography because in FFA we can delineate only superficial capillary plexus. In OCT angiography, both superficial and deep capillary plexus can be delineated.